And go live. There we go. Okay, so we'll start with, let's start with murmurs. Is that cool? So when we're listening for murmurs specifically, not just regular heart sounds, which part of the stethoscope are we wanting to use?
The bell.
Right. The bell is better for hearing, like, the flip side of that back side of the stethoscope is better for hearing like the lower tones, and the regular side of the stethoscope is better for hearing like higher tones, like vowel sounds that are more high pitched, and murmurs tend to be more low pitched, and so the bell tends to pick up on those better. So if you're specifically looking for murmurs, it's better to use the bell of the stethoscope. Now, if someone does have a murmur, let me just draw a heart here. Where do you tend to hear murmurs the clearest?
The apex.
And which side? Yes, on the left side. You hear them tend to, the apex on the left side, if they're positioned on their left side. Like have the patient positioned onto their left as you listen to the apex. Does that make sense? If for some reason it just helps you to hear it better. Now, if you're listening and you hear, let's see how, lub, dub, ta, which murmur is that?
She said it was S3.
Yep. So that's an S3 sound. This is the one that's also called the gallop. That sounds like the horse's hooves going. So la da ta, la da ta, la da ta. And what does this murmur indicate if you hear this?
Why is anything that's causing difficulties for the ventricle to fill? So it's like something resisting filling. So there might be like a, would that be a mitral valve defect?
This is the ventricle here. Anything that causes fluid overload. Remember when we talked about in CHF that S3 murmur is common with CHF because the congestive heart failure has to do with the excess fluid, right? Which is part of where we get the congestive from. So anytime that there's excess fluid in the heart, the murmur that you're going to tend to hear is the S3, the lub dub ta.
So is that like would the fluid be coming back from the lungs then?
Well, no, remember this is before the lungs. The lungs are between the right side and the left. So if you'd hear fluid backing up into the lungs, but the lungs isn't causing this side causes it to the lungs. Right? Remember? So just when there's too much fluid in the heart backed up, it tends to make that sound. Now on the other end, you hear it before, you hear ta, lub, dub. What is this one?
She said ventricle resistance from an atrial kick during presystole. I don't know what that means.
In my notes, they're explained a little bit different, but it should be the same information. This one's the S4. Yeah. We call this one the S4. Yeah. And this one, from my notes, talk about how it's remember we talked about in CHF, when the heart tries to compensate, it starts hypertrophying, getting bigger, the heart muscle gets bigger. So when the heart muscle gets bigger to try and get stronger, which it doesn't actually, to kick the blood out to overcome the systemic vascular resistance, you'll hear the S4, which is symbolic of, okay, the heart is getting hypertrophy, growing bigger, or cardiomegaly is another way to call it. Does that make sense?
Okay.
So they're kind of related, remember, because in CHF, it's the excess fluid that weakens the heart, and then that causes the heart to hypertrophy. So an S3 murmur could lead to an S4 murmur, right? So fluid overload can lead to hypertrophy, just like when we talked about in the CHF lecture. Does that make sense? Mm-hmm. So fluid comes first, weakens, stretches out the heart like a big balloon or big rubber band. Heart tries to compensate by building up more muscle, and that's when you hear S4. Clear as mud. Don't you guys have a test soon?
It was supposed to be Friday, but she just moved it to next Wednesday.
Oh, nice.
Which is because there's a child health test next day. So.
So it's mixed blessing.
Some people really need it.
That makes sense. Well, it's good. More time to study. So can you erase this? Yeah. All right, so we're gonna move on to the itises, all the different kinds. So I know that this isn't what the heart looks like, but just for the sake of the drawing, this is what it's gonna be. Oh, that's really uneven. That's gonna bother me. So
It's never gonna
it's
be
fine.
perfect.
It's, you know, it is what it is. It's all good. Okay, so I'm just gonna make a quick little diagram and it might help visualize more of what the heart looks like for the itises. So this red stuff is gonna be the heart muscle. Just gonna go all the way around. Doesn't have to be super pretty. Stunning. Okay, so the red we're gonna call the myocardium, which is just a fancy way for saying heart muscle, because myo means muscle and cardium means heart. The black here is going to be the inner layer. So this is the endocardium. So endo meaning inner and cardium meaning heart. Then you have another layer surrounding the heart muscle. This is the epicardium. There's a lot of cardiums. Epicardium. Then we have this. I'm going to use blue, and I'm going to go like this to indicate fluid. You're supposed to be waves. Like
I get that.
So this is technically the pericardial space where there's fluid inside to create like lubrication. Because if you have something that's constantly moving, it's to build up friction, right? And it creates heat. So the fluid helps, keep it lubricated and keep it from getting overheated. What did I just say this was? Pericardial space. So you do have some fluid in there to keep it nice and smooth. And then after that is the pericardium. So that's the last thing. And this is a sac that holds the fluid inside. You'll hear it called the pericardium or the pericardial sac. I'm just going to put pericardium sac there. So you got your kind of like a Ziploc bag holding in the fluid, and then you got the layers of the heart. So you can have different problems in any one of these layers, which causes the different itises, just inflammation of whichever part we're talking about. So if we're going to start with endocarditis, which one is the one that's being inflamed? The endocardium, right? So this is the very inner layer. So this is the layer that, like, if you were to like dissect the heart and open it up, it would be like the inner chambers of the heart, including the valves. So I guess I'll put.
So the valves are included in any endocarditis.
I know that this is not what it looks like, but it's fine. Yeah.
Hughes's artwork was very much the same, so.
You get it. You get it. You get it. So infective endocarditis. It's going to be inflammation of the inner lining. So inside the inner lining of the chambers and the valves. What are some reasons or risk factors that puts you at a higher chance of getting endocarditis?
Infection, bacterial or viral, or right? It wasn't there.
There's various risk factors. I promise you that age is probably going to be a risk factor for everything.
Okay.
So we're going to put age. Anytime you get older, you have a risk factor for pretty much everything. What about a decreased immune system?
Yeah, immunodeficiency.
Because it's infective, right?
Yeah, is it infected? Okay.
Yeah.
Yeah.
So weakened immune system, you're more likely to get infective endocarditis.
Yeah. Having a metal valve, she mentioned.
Having a what?
Prosthetic valve.
Yes, I was about to write that one. So the reason why prosthetic valves, or let me ask you, why do you think a prosthetic valve would be an increased risk factor for
Well,
endocarditis?
they're often metal. There's a metal involved, and metal attracts clots. But I imagine it also can fail. It's more likely to fail than a natural.
Also, there's, for some reason, like whenever there's a non-like organic, like non-like alive thing in someone's body, like if there tends to be like bacteria tend to colonize on it. Not sure why. Like people get like knee replacements. Sometimes they can go bad. I was in the hospital yesterday with a clinical group, and there's this one lady who's had surgery on her right knee 7 times because it keeps getting infected because she's got like implants or rods in it. And like just for some people, whenever you have like a foreign device in your body, like bacteria tend to congregate there and just cause an infection. So imagine having that inside your heart, it increases the likelihood. And then what's the big one? The big one that and it's kind of bad because whenever someone comes into the ER with endocarditis, the first thing people think of to say, IV drugs. And that's not always the case because there's, people that don't use IV drugs that get endocarditis, but this is like kind of a big one. Like a lot of people.
Is it the most common cause of endocarditis?
Well, especially in like certain like Chattanooga, places that are known for like certain drugs and things, you're like, you're coming to the ER with endocarditis, and you can kind of spot people. They kind of like have that look. Yeah. So it's common. There are other reasons obviously, but it tends to be one of the first things people think of,
especially if they're younger.
Yeah.
Or under 60.
Yeah, right. If they don't have any of these other risk factors, you're like, well, it's probably IV drugs, right? If they're like a young person, they don't have any of these other things going on. Okay, so just imagine that this person has endocarditis, their valves, their chambers are inflamed. What kind of signs and symptoms would you expect to see in this type of person?
She also mentioned dental.
Oh yeah. So
is that just because bacteria can get in the bloodstream?
Yeah, I'm not actually sure why that's a risk factor. But whenever people have like invasive
she did say, she said
invasive dental work, that it can happen. So a lot of the times, like they'll put people on like prophylactic antibiotics after dental work. Not so much. Well, yes, also to help with their infection in their mouth or prevent infection building up there, but to protect the heart as well. I can't remember. I'm trying to remember back when I was in school a long time ago, but they were explaining that like it's just really close, like from the mouth to the heart. Like there's like a certain blood supply that like flows directly there, so it tends to happen. I'm not really sure about the anatomy of it, but they do say that like if you have heart issues and that you've had endocarditis before, that you make sure you take prophylactic antibiotics before any dental work, because you just have a tendency for it. That makes sense. I'm pretty sure people that have like prosthetic valves and stuff, they have to like take antibiotics before they go do dental work and things like that. Okay. Yes. Anyways, thank you for reminding me of that one. Back to signs and symptoms. Try to imagine what kind of signs and symptoms what would make sense with this diagnosis.
Well, hearing the murmur.
So murmur, obviously their heart's in distress. It's going to cause murmur. What else? They have an infection. So.
Fever.
Yeah, typical infection things. Fever. The other interesting thing that is kind of out there is what else do you see? Like when you get imaging, what tends to pop up on imaging when someone has endocarditis? Like what can you see? Like if you get like an echocardiogram or X-ray.
Would there be regurgitation? Because it's on the valves, would there be blood regurgitation? Or
there could be.
Heart failure.
There could be, especially if there's something wrong with the valve that could cause regurg. What I'm thinking of is, I don't know if she mentioned the vegetative formations.
Oh, she did.
Yeah, so I've seen a few like pictures on the internet, and like for whatever reason, like these little, I don't know how to draw this, but like these little like cauliflower looking things start growing. And as you can probably imagine, that can cause problems, especially if that were to grow near a valve. Imagine if like this cauliflower like thing grows right near that valve. Now suddenly you have a problem with blood flow. Well, that's actually the wrong direction. You have a problem with blood flow getting through, right? No, it was the right direction.
I was gonna say, wait.
Sorry, I was
just changed it all my.
Yeah, no, you're good. I just woke up from a nap. If you have these things growing in front of a valve, it could block the flow, which can cause the regurg, and if you start having problems with the blood flow, now you suddenly have fluid buildup, right? So what can that lead to? That can lead to heart failure, and it's not even related to, you having high blood pressure or fluid overload. It's just related to something's wrong with your valves. And so you go like, oh, look, you have a vegetative formation blocking your valves. So that's why they always do like imaging to see why you have CHF, because it could be from various reasons. Okay. So it's not always because you've had hypertension your whole life and haven't treated it. Usually, but not always. Okay, so how are you going to diagnose this person? So maybe you suspect someone has endocarditis. They come in, they're young, they're not old. It's kind of weird that this person has cardiac issues. They have a fever. They're complaining of chest pain and different things. Like, how are you going to diagnose it for sure?
I mean the echocardium.
Yeah. So imaging, obviously.
Yeah.
So that's the diagnosis. You're going to use echo to take a picture and take a video of what's going on. Also blood cultures. Blood cultures are a big one because they have the infection, right? So be in their bloodstream. And if it pops up on the blood cultures, you're like, okay, yeah, they have an infection in the bloodstream. See that all on the echocardiogram. There you go. What about treatment? How do you treat it?
Antibiotics.
Yep, obviously antibiotics. What else? What are we worried about anytime there's something wrong with the heart?
Heparin.
Yeah, so clots are a big thing, right? Yeah. Anytime there's anything interrupting the blood flow, it can get stagnant, just like a nasty lake, just fluid sitting on top. You want it to be constantly flowing out so it doesn't sit there in a pool and start to get clotty. So they're going to have to be on anticoags or anticoagulants during this time. So anticoags. And then what else might they need? Let's say they do have vegetative formation or they do have a valve issue. How are you going to fix that?
Oh, I thought the antibiotics would fix that.
Well, that fixes the infection, right? But if they have a vegetative thing growing here, or they have something wrong with their...
Does that have to be removed?
Mm-hmm.
Wow,
so surgery is another treatment. If they need a valve replaced, okay. Obviously they have to do surgery. If they have an abscess, do you know what an abscess is?
Well, it's like a pus filled.
Yeah, like a big nasty kind of like a cyst thing. Like a dead spot with pus, they have to take that out. So surgery is sometimes needed, sometimes not, depending on what's going on. So, all right. Any questions about endocarditis? No?
Would sudden weight gain just because of the
fluid
retention?
Possibly, yeah. I'm gonna go ahead and erase this one. You better be taking notes back there, sir.
He's learning lots.
He's my bride. I told him he has to come and learn all the nursing things. He's a pilot, so
I was gonna say, what do you do?
He doesn't care about this stuff at all.
You might get someone with endocarditis.
Hey, if someone on the plane drops over and you're like, oh look, they have a fever and chest pain, they might have endocarditis.
Someone's like, what are you gonna do?
I don't know.
Keep flying.
Open heart surgery right now on the plane.
Over here so I can inspect your pericardium.
We haven't gotten there yet. We have an endocardium. Okay, now we're gonna do pericarditis. 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 So this is inflammation of the outer sac. So just off the top of your head, what kind of problems do you think that can pose?
Constriction of the heart.
Yeah, so it holds the whole heart together, right? So if that thing is constricting and it's like, okay, problem, right? So what are some risk factors that put you at risk for developing this?
Would it also be infection, like bacteria, or?
Yeah, this one's more of an inflammation thing. rather than like necessarily an infection. That's what they call it, infective endocarditis. This one's just, itis means inflammation of.
Okay.
So like tonsillitis, inflamed tonsils. So this one, anytime that you have like a scenario in your body where you have like chronic inflammation, and a lot of people have this problem. So anything causing chronic inflammation, there are certain, what's that one disease? The autoimmune, is it lupus?
Wait a minute, multiple sclerosis?
Whatever it is, whenever you have chronic inflammation in your body, it puts your pericardium at risk for being inflamed too.
Lupus.
Yeah, so that's
I
it.
think that's one.
Yeah.
I think there's more than one.
There's lots of kind of autoimmune things that cause like a lot of massive like systemic wide inflammation. Another thing would be like radiation and chemo put you at risk just because your whole body is like, what the heck's going on?
Oh, tuberculosis I mentioned.
Chemo, so just cancer in general.
I saw a patient who had surgery to remove clots. He had some sort of bleeding or blood disorder where he was just throwing out clots all over. And they removed all these clots, and then on his way from ICU, he threw another clot, and I heard a cardiac rub. That sound,
Yeah.
which was fascinating, sad, but
Yeah.
fascinating. Was it the surgery or was it the clot? Like what would cause?
I mean, he probably just has a heart condition where he's like, there's a lot of problems with the heart, and so you're hearing that, and that's probably why he's throwing so many clots. I'm not sure what the situation is.
I didn't know what was causing him to clot so much.
Oh, then I don't know.
But I was just kind of like, none of these seem to line up with.
Yeah. Anytime there's an issue with the heart, you want to think about clotting. So, just in general. Are some other ones? I'm not really sure exactly what I can speculate, but they had renal failure on the notes. Do they have that on yours too?
Mm-hmm.
The only thing I can think of is that the kidneys are what's responsible for cleansing the blood of toxins. So if the kidneys aren't doing their job and they're not cleansing the body of toxins, then those toxins can everything in your body gets filtered through the heart also. So it probably just very irritating to the heart. I mean, you got all sorts of toxins in your body that can irritate it. So I'm guessing that would be why. Yeah, so that's that. All right, so signs and symptoms. You got an inflamed sac here. What do you expect to see?
Muffled heart sounds. Chest pain.
Yeah, so specifically the pleuritic chest pain too, which is like has something to do with the lungs. So like we're having to do with when you breathe and swallow and that sort of thing.
Is that just because of the pressure, or what is the why?
I'm just assuming that like the heart is being squeezed and that's affecting the lungs too, because everything, you go from this side to the lungs and then back to this side. So everything that affects the heart will eventually go to the lungs as well, back up through the pulmonic veins and arteries. So and also I guess when you breathe in, this is probably what it is. When you breathe in, it brings in more pressure. So now it's even more pressure, like squeezing the heart. So then when you exhale, it's like, okay, relieving the pressure, more pressure in, squeezing the heart even more. Does that make sense? Mm-hmm. That's probably also what it is. Probably the same thing with coughing. You're coughing. That's a strong, like tensing moment, putting pressure on the heart. Yeah, so like you can tell if like when you breathe in, cough or swallow and it's more painful, that's pleuritic chest pain. Some other signs and symptoms. Generic, I should have added these to the other one as well, along with fever, but
yeah, like white blood cells.
Yeah, white blood cells increase.
Inflammatory markers.
Yeah. And then this is also what you would hear when you mentioned the friction rub. When you're listening to the heart sounds. Have you ever heard like the sound of like, how to explain this? Like have you ever ridden a horse? So you the sound like the saddle makes when it's kind of like creaking and like that. I can't do it, but you know what I'm talking. The sound that the leather makes when it's kind of stretching, like that's kind of what the friction rubs sound like, and it's like again, this is being inflamed, which is what's holding the water. And so it's like, this is supposed to help with friction, but if the sac is inflamed, then it's like, it's going to be causing friction instead of helping with friction. So you're going to hear friction rub.
Okay.
Does that make sense? So like if this is getting bigger and inflamed, it's probably going to be rubbing against this. So the the epicardium might be touching this now because it's so inflamed, you know? So you would hear the rub of these two rubbing against each other.
Okay.
Let's see. What else? Friction rub. When do you hear the friction rub? Is another good question. They might ask you that in the test.
Well, when there's fluid buildup in the.
Sorry, I should
pericardium?
say, not like when, as you're listening to the patient, when can you hear it best? Between breaths, I mean.
Okay.
So at the end of their expiration, after they breathe out, you'll hear it. And I assume that's because like you're putting out all of your air, and then that's when you can finally hear the rub, because there might be other, like the breathing in, breathing out at the end of their breath. So like, then you'll hear that rubbing sound. It's very uncomfortable to listen to. It just sounds like grinding.
Yeah, I got to hear it.
It's
No,
like,
actually,
don't
the
like it.
patient was, he didn't quite code, but it was a rapid, and so there was no asking him to hold his breath, so I didn't get that opportunity. Like, could you hold your breath? So I can. It was, so I wasn't sure if it was.
So end of expiration,
Okay.
and on my notes it said the left lower sternal border is where you'll hear it best. I'm sure you can hear it other places as well, but you know, you have like your chest, you know, your sternum right here on the left lower.
Well, she said that. I wrote it all down. It is in there.
Okay. I mean, this diagnosis question is kind of going to be very similar, but how do you diagnose this?
Oh, well, I guess you'd have to do a scan, but listen, you know, if you heard that sound, but she also mentioned Beck's triad.
Oh, what is that one?
Muffled heart sounds,
Okay.
decrease or blood pressure decrease, but also the systolic and diastolic are closer, grow closer together, and then jugular vein distension.
Okay, yeah, I didn't know that was called a
Beck's
triad. Yeah. You also can look at EKGs. What would you see on an EKG?
She said ST elevation in all leads is.
Yeah. So when the heart's in distress, you know, you're gonna see like the ST elevation, and that I'm gonna put ST-LE. Do you know what that looks like?
Yeah. So you have your QRS, and instead of it going down and then back up into a T wave, it just kind of curves over to the T wave.
Let me erase that.
It doesn't quite go down, and it curves up into the T.
Yeah, something like
Yeah,
that.
yeah. That's what I picture in my head.
Beautiful.
Beautiful elevation.
Yeah. The other thing is that this can lead to another problem. What other problem? I mean, if this isn't a big enough problem already, what can pericarditis lead to? That's another problem.
I imagine, you know, heart failure and maybe like an MI, because
I think Professor here said she's had this.
I guess they removed part of her pericardium, and then they ended up using it to repair the hole in her heart.
Cardiac tamponade. Did she say she's had that? Or was that?
I think she mentioned that, yeah, they had to release.
I can't remember what she said that she had, but this can lead to cardiac tamponade, and that's when like the fluid starts accumulating. And in my mind, I don't always know if this is the right answer, but it makes sense to me that this would happen. Like if you have the friction rub, right? Because this is getting inflamed, which would mean that these two things are growing closer together, because whenever something gets swollen, they get bigger, right? So these two things might start rubbing against each other, making that sound. My mind is like, okay, well, you got the fluid in here to prevent that, right? To keep the friction from being there, to keep it lubricated. So they're probably going to start producing more fluid to help out with that friction, right? And so then cardiac tamponade is when a bunch of fluid starts accumulating in here to the point where like the fluid adds all this pressure on top of the heart, and it's like squishing and squashing the heart with all this extra fluid. So I can't really, I don't know how to draw that, but like.
Is that not inflammatory? Is that not necessarily inflammation?
Is what inflammation?
Cardiac tamponade, is that not caused by inflammation?
No, I'm saying that pericarditis can lead to cardiac tamponade. Yeah, so that's what I was saying, like, if these two things are rubbing together, they're probably gonna start producing more fluid to lubricate it, to get rid of the friction problem. But then now you have all this extra fluid kind of on top of the heart, adding more weight and pressure that's like squishing it.
Okay.
Does that make sense? And then how do you get rid of the fluid when you have cardiac tamponade?
Cardio or pericarditis.
Yeah, okay. And that's when they literally have to inject a needle through the layer of your heart and aspirate that fluid out.
She also mentioned, like you said, she called it a pericardial window, that they actually cut a piece of the pericardium out.
Is that what she had?
Yeah.
Okay, yeah,
And
I
they
had.
use that piece to repair the hole in her heart. Like they use the actual piece of the pericardium.
Wow,
So then she didn't have about, anything.
that's a whole other
Foreign.
case study.
That's
Yeah,
cool.
so they literally will inject
She
a
should do a
needle
case study on herself.
in here and suck out that fluid so they can take out all that pressure on the heart, because like it's hard to beat when you've got like tons of fluid like just surrounding you. So I often imagine that would be a fun procedure to have.
I imagine they had her chest open, so they just did it. I don't know.
Yeah,
Oh,
I don't actually know. Pericardiocentesis. Yeah. All right, so how do we treat this? What do we do?
NSAIDs?
Mm-hmm.
Like
And what are NSAIDs?
anti-inflammatories.
Right, so treat it with non-steroidal anti-inflammatories, because what's the problem? Inflammation, right?
Right.
What else can you give them?
Steroids, like
Yeah.
non-steroidal and steroid.
Yeah, non-steroidal and steroidal. And then also antibiotics too. Just, in general. Just in case there's any bacterial.
If it's bacterial
Yeah,
cause.
yeah.
I
I don't think NSAIDs are a treatment on any of the other ones. I think that one's probably the differentiation. Yeah.
Well, for rheumatic heart disease, it says anti-inflammatory drugs.
Okay. Well,
I don't know if it's specifically NSAIDs.
all right. We good on this one?
She said positioning, hemodialysis if kidney failure is the cause.
Mm-hmm. Right. Again, you have to know what's causing it to be able to fix it.
Pericardiectomy is
Yeah. If you have renal
remove
failure,
part of it.
well, if you have renal failure and that's giving you pericarditis, probably dialysis will be a better treatment, right? So it kind of just depends on what's causing it. So. You ready for me to erase this?
Mhm.
Okay. I'll do some quizzing of you at the end if that's amenable to you. How do you feel about that?
It's fine. It'll help.
Look at you getting this one-on-one tutor session.
Yeah, it's gonna listen. Just keep thinking everyone's gonna listen. To my
I'll
silly
leave
questions.
that there. I'll just leave that there. All right, the next one is myocarditis.
Okay, we're in a different order in our notes, but that's fine.
Oh, I'm sorry.
That's fine.
I just like to do the itises and then do the rheumatic one just because it doesn't have an itis and it bothers me.
As much as your crooked heart.
Yeah, well, I've tried fixing it and it's just not gonna. Myocarditis. Okay, so what is this an inflammation of?
Myocardium.
All right, so the actual muscle itself, right? So I guess in some ways, I wonder how they different. I don't have an answer for this, but I'm just thinking if someone were to
How
take
they know.
an X-ray, how can they tell if it's myocarditis versus like hypertrophy? But I guess the hypertrophy is probably localized to this ventricle. That would make sense. And then myocarditis is probably the whole thing, I'm just brainstorming out loud. So I'm just thinking, both of them get bigger. How
You
you
might
do
see
it.
the bulging going out, but not see the pericardial sac filling with fluid.
Yeah,
as
because
opposed
like
to, I don't
hypertrophy,
know.
remember how like last time in the previous lecture, I was talking about how the myocardium of the ventricle starts to get smaller and it decreases the amount of space for blood in the middle. and it's mostly localized to this one spot, versus the myocarditis is probably the whole heart, so it's probably hard to tell the difference.
I think she mentioned.
That would be a question I would ask. I don't
It could
want
be
to put
anywhere.
false ideas into your head, so. But that's just something I just thought of just now. This is recording sound. I think it is. Okay. That'd be sad.
You think of it now.
I'm like, oh, well, I just feel like it should be. Okay. All right, what are some risk factors for this one?
Would it also be infection, viral?
Yeah, this
Because we
one's
have,
specifically viral.
I was gonna say there's yeah, we've learned that with COVID.
Yeah.
Myocarditis in the vaccine.
Yeah, this one's specifically, yep, specifically viral. Whereas the other one is the other ones are usually bacteria. You know, like usually infections are like when we treat them with antibiotics, you know, they're because it's bacteria. But this one's specifically viral. You can also have this again. You said about the vaccine, viral and drug reactions. So both of those things are relevant to, you know, things happening today. So you can have a drug reaction, you know, to a specific drug or even a vaccine, viral things causing myocarditis. Those are both risk factors. So if your whole heart muscle is becoming inflamed, what kind of signs and symptoms, side effects are you going to expect to see?
Well, I imagine it wouldn't work as well. So you'd see signs of heart failure. Could it be both sides?
Well, chest pain for one.
Okay.
Yeah.
So I'm thinking, yeah, okay. So
Chest pain is probably going to be like indicative of all of them.
crackles in the lungs.
Arrhythmias for sure.
Arrhythmias, okay.
Because the muscles are what, you know, cause the heartbeat, right? It's the love dub, it's the squeezing.
Okay.
So if the muscles themselves are, you know, impaired because of inflammation, you're probably going to have some arrhythmias. So when we have arrhythmias, what are we thinking about? What can arrhythmias cause? If it's not clots. So that's bad. Clots, which can lead to strokes.
Or MI, because the
Yeah.
clot could go.
It depends. Yeah, it depends where the clot goes. If it goes to the brain, stroke. If it goes to the heart, you know, heart attack. What else? Shortness of breath, obviously, because whenever we have arrhythmias, we don't get great perfusion. We don't have great oxygenation. So you're feeling short of breath because you're not getting the oxygen to your extremities that you need because of reduced cardiac output, right? Okay. Arrhythmia is always, the two things you always want to think of with arrhythmias are clots and cardiac output, right? Because if it's not pumping adequately, those are the two things that are going to be affected. You're not getting the blood flowing good, so you can build up clots. You're not getting the blood flowing well, so you're probably not going to have great cardiac output, not great perfusion, not great oxygenation. What else?
She mentioned fluid buildup with swelling of the legs, ankles, and feet.
Yep.
Is that just because there's inflammation in the leaky vessels, or what?
Well, the reduced cardiac output, it's backing up, right? So if it can't get out, it backs up here. If it can't get out, it keeps just backing up all the way down systemically. And then gravity just pulls the fluid down. So if you've got fluid in your body, it's going to naturally pull in your feet and ankles because that's just where gravity is going to go. If we've walked on our hands our whole life, they probably have swelling in their hands and wrists, you know, so it's just the gravity. What else? General feeling of, you know, if it's viral induced, general feeling of malaise, sickness, headache, fever, the typical virally feeling. So treatments, there wasn't a lot on your notes for treatments, was there?
Yeah, it usually goes away without permanent effects.
You can't really, here's the thing, like we can't really treat viruses, you know, like we don't have antibiotics for viruses, right? So typically when someone has like a cold or a flu or something else that's viral, you just treat the symptoms. So it's just symptomatic care. There's not really like a cure to fix it. And your body usually fights off viruses on its own eventually, hopefully. And so preventative care, I think, is the one thing that they were stressing in your notes. is to just,
Yeah.
make sure that you're, just anything that you do to prevent getting sick, general hand hygiene. What else do they have on your notes for that?
Hand hygiene, avoid being around infectious people, and vaccines. Talk to primary about risks versus benefits, but she did also mention that it can cause heart failure, and I wrote in, before it gets worse, give beta blocker, antihypertensive.
Oh yeah, of course this can cause heart failure. It can
So
also
just
cause
like
strokes and heart attacks.
Treat the possible effects.
Yeah. So
treat the possible
treat
complications.
things from getting worse, right? So
Right.
if they are having like heart failure like symptoms, then you would treat it like heart failure, like you would when we talked about last lecture about CHF and things like that.
Okay.
So beta blockers, because with heart failure, the heart is wore out, right? It's working too hard and it's not having enough, it's not getting enough results. And so you want to give the heart a break.
Diuretics and
Right, so diuretics, get some of that fluid off,
antihypertensives.
antihypertensives, yes. So it's not really treating the cause, you can't really treat a virus, but you treat the symptoms of it. So that's really just symptomatic care. So either your body will get over it on its own, or you'll have to be hospitalized to deal with preventing clots and all the other heart failure things. So you either get better or you won't, one of the two. It's either or. Yeah, so there's not as much.
You won't.
Yeah, it's not. There's not as much on this one compared to the other ones.
Nurse, we're gonna be okay. You'll either get better or you won't.
Right. That is true, right? Okay, now we can do the rheumatic.
Oh yeah.
What do they call it? Rheumatic fever? Is that what?
Rheumatic heart disease is what I call it.
Is there a rheumatic fever too?
Yeah.
Okay, yeah, that's why I always want to call it that.
I always thought that strep throat could lead to rheumatic fever eventually, like strep throat, and then it becomes scarlet fever, and then it becomes rheumatic fever. But
something like that.
she differentiated them, so
Yeah.
I'll have to look
And then
that
there's
up.
rheumatoid arthritis.
Yeah.
So
I had one of my boys had strep throat. It was right around Christmas time, so we were like, it got better, and so we're like, oh, okay, he's fine. And then he got this rash, and we're like, well, it's Christmas day or whatever. So we're like, well, let's take him on Monday, but then he got better, and then he like couldn't walk, his ankles and his wrists, and he was like 18 months old.
Wow.
So we ended up taking, we're like, well, he had strep throat, but it doesn't need to be treated at this point. So we like had his heart checked and everything, he's fine, but it was very concerning.
Yeah.
I remember they wanted to listen to his heart and check his heart and
For sure.
make sure everything was okay. His pediatrician said he was fine.
Because how this can affect the heart is what it does is like it can permanently damage valves. So these little guys, what do they call it? Rheumatic what? Sorry.
Heart disease.
Thank you. Heart disease. So the valves can get permanently messed up, which anytime there's valve issues, there's a problem with flow, right? This is going to be impaired. This is going to be impaired. So then we have all the same issues with fluid shifting, right? If the fluid can't get out, it's going to back up, right? So all of these things can lead to heart failure with the congestion and the fluid overload, right? So valves that don't work, it's very bad. You need them to work. So you might have to do surgery if it gets to the point where the blood, they're just so blocked off from being inflamed that you have to get prosthetics. So maybe, back to endocarditis, maybe someone was a kid and got the scarlet fever and all of those things, got the messed up heart valves. Now they have prosthetic ones, and those got infected, and they got endocarditis. Could be. See the chain of events here?
Yeah.
Okay, so risk factors. Strep infection. Like we mentioned, strep. That could be strep throat, or like you said, scarlet fever. That's a very big T there. Scarlet fever. Those are risk factors. All right, signs and symptoms. valves aren't working. So we'll just put fever on here, obviously. What else?
Well, she mentioned the painful joints.
Just that's what made me think of the rheumatic or rheumatoid arthritis.
Yeah.
So pain in joints.
Nodules, what are those, lymph?
Yeah, they're just like little bumps under the skin. I'm assuming. Yeah, you said lymph. I'm assuming so. It also is the rash, and that's what ties me into like the scarlet fever thing.
Yeah.
Shortness of breath. Pretty much shortness of breath is going to be a sign and symptom of all of them. Same thing with chest pain. That's going to be pretty much a sign and symptom for all of them.
Like the things that are different, I'll start.
Yeah, this one is very different. I mean, you don't have nodules, rash, and pain in joints or any of the other ones. Yeah, it's good to be able to highlight the ones that are different because there's a lot that are going to be similar. Right? It's like patient comes in with shortness of breath and chest pain. It's like, well, thanks. That could literally be 5 different things. So, how do we treat this?
Antibiotics. Well, prevent it by treating.
First of
strep
all,
or
yeah, if you have strep, don't just live your life without treating that.
Yeah.
Right? Get it fixed. Steroids, antibiotics, steroids, and steroids are just potent. Like they reduce inflammation. So it's the inflammation that's causing the swelling and the scarring and the messing up of the valves.
She did mention anti-inflammatory drugs.
Yeah, that's
name NSAIDs.
Yeah, I'm assuming that's probably NSAIDs and steroids. Just like it was for pericarditis.
And then the surgery, you're talking about possible valve.
Yeah, they might have to get their valves removed if they don't respond or they're just so far gone or like they literally are blocked and the blood is not moving. You have to have surgery kind of right now. You can't just wait, 48 hours for the drugs to kick in because you might have to have your heart beat once or twice between now and then. So you might have to have emergency surgery. Who knows?
Okay.
How do you feel about the itises?
All right.
I think you're all right. Do you ever use Khan Academy?
I have. My son uses it a lot. My kids like it.
Yeah, I love it. They have lots of good stuff on there.
It's
Nice
nice because I don't
pictures.
remember how to do long division, and they do. So, how do I do long division?
I haven't used long division since
Oh.
I was in middle school.
Me neither. I feel bad with him learning it because I'm like, can I teach how to do your taxes?
Yeah, that's the one thing. Like, I'm not gonna be able to help my future children with math and be like, sorry, like, I can't help you.
I can't teach you something more practical.
I can teach you nursing, but I
Yeah.
cannot teach you math. That's just not
Yeah.
happening. All right, moving on. I don't know what's next in yours, but I'm gonna do thoracic aortic aneurysm.
That's it.
Okay. I'm just gonna put TAA, that's fine. I don't feel like writing all of that. Okay, so what even is an aneurysm?
A bulging of a vessel of
Yes.
an aorta.
Specifically, yeah. So if this is
this
your-
is the aorta, but
If this is your blood vessel, it's just whenever for whatever reason, the lining of the vessels get weak, and so they start pooching out. Is that a word, pooching? Pouching, whatever it is. So these are supposed to be like firm, and strong, so that it can withstand the flow of blood going through and the pressure that's exerting out, right? But sometimes the lining gets weak, and then if it's weak, there's still pressure pushing out, and it's going to cause it to balloon out until it bursts, right? And we don't want it to burst because that's bad. So when that happens, okay, so TAA, there's two types. You can have either a dissection or a rupture, right? Dissection and rupture. So this is a rupture, right? It explodes like a pimple. And so obviously that's bad because now all the blood that was supposed to be inside of your aorta is now going out of your aorta and spewing all out throughout your body. You have internal bleeding, and that's not good. So that's a rupture. Dissection is a step down from a rupture. It's just when it's ruptured within the vessel, but not outside of the vessel. So you know how like you have layers to your heart, your vessels also have layers. And I don't remember the names of them right now, but there's like, gosh, I know there's like a muscular layer, I think, and then there's like the cellular layer, whatever it is. There's multiple layers within your vessels. And let's say this one ruptures, right? So all the blood is supposed to be in the middle, right? But now it can like get in between the layers, if that makes sense. Does that make sense? So that's a dissection. Yes, the bleeding is confined within the layers, so it's not bleeding out, but it's still not great because it's still not going where it's supposed to be going. But a rupture is way worse because you could just bleed out entirely. Now, let's see. What kind of risk factors are there that contribute to someone developing this?
Oh, that's okay. I was thinking high blood pressure.
Yeah, exactly. So this one, obviously,
Yeah.
high hypertension, right? The more pressure you have inside of your vessels, obviously, it's going to get to the point where it's going to rupture, right? So that's just common sense. Hypertension for sure. What else?
High cholesterol. Can you explain that?
Yeah, so high cholesterol, you know, it typically leads to like buildup of plaque inside the arteries.
Right.
So.
And actually atherosclerosis.
Yeah.
Isn't atherosclerosis is the plaque buildup.
Cholesterol usually leads to that. So
Okay.
when you have like
So
this
it kind of relates.
plaque buildup here,
Yeah.
these risk factors aren't always like different, but like contributing.
Yeah.
So like if you have high cholesterol, you're probably going to have atherosclerosis. And if you have atherosclerosis, you're probably going to have hypertension. Why? Because if you have a plaque buildup, you've just done what? You've just narrowed the opening, right? And when we talked last time about whenever you narrow an opening, it builds up the pressure, just like a hose. You just let the hose run, it comes out, you know, not very fast. You put your thumb over a part of it and you leave a small opening, the water starts spurting, right? So there's more pressure. So they just narrowed the opening here. So that's how you have cholesterol that leads to atherosclerosis, which leads to hypertension.
So would just the high pressure, would the rupture or dissection occur at the top of the vessel in your picture? Is that?
Probably. I mean, it would have to. I mean,
Would
it
it
would
be
make
from
sense.
the cholesterol breaking off and causing damage when it breaks off?
That's also. I'm trying to remember.
It doesn't matter. I don't need to know, but
I watched a video
just
about
picture
this.
it. Okay.
Having this here is also just highly irritating to the vessel lining too, which can weaken it, and you get like micro cuts in the lining, you know.
Okay.
And then like that can lead to like clot buildup, that can lead to like just a weakening in general, and so rupture, dissection related to that, and just the hypertension in general.
Marfan syndrome is a concave chest, and that they just tend to have cardiac issues.
Oh, I was gonna look that up. I forgot to look that up.
Tall.
That's what?
So they're super tall. I feel like.
Oh my gosh, do you have Marfan syndrome?
Go like this.
Wait, what is that?
I guess if their thumb like extends beyond their, usually they'll go out like that.
Oh my gosh,
far.
my thumb goes
I know
beyond.
mine goes really close, but they're tall. They're like 7 feet tall.
He's 6'7".
I heard somebody say that once before.
But
What?
they usually have a concave chest and have heart issues.
Do you have a concave chest?
You know, the hardest question.
I think to be a pilot, don't they do
You
extensions?
probably have to
Goals
check
for you.
that. Oh, that's
I don't
funny.
think they let someone with Marfan's yet.
That's really funny. I'm glad you don't have that. Yeah, I don't know much about. I had written a note to myself to look that up, and I didn't. So I know nothing about Marfan syndrome. So sorry. But apparently, the thumb trick is all I know now.
I watched a bunch of videos and kids and I were interested.
Sounds like Martian syndrome, an alien, it's really tall. All right, signs and symptoms.
They're aliens.
Guessing, obviously, your thing just ruptured. What are you gonna feel?
Pain.
Yeah, obviously. Where are you gonna feel it?
In the chest or anywhere wherever the rupture is.
Yeah, they say that.
Be,
Yeah, the aorta's kind of big, so it's
I was
like
gonna say, can it
yeah.
be in the abdomen?
they say that it tends to be either like near the heart or in the back.
Oh, okay.
back pain. So they also say that people have a hoarse voice, and I have zero idea how that's related.
Laryngeal nerve is affected.
Sure, the laryngeal nerve is
Am I
affected.
pronouncing it right?
Yeah, I did not know that.
She said that's different from other conditions. That's a differentiating symptom.
Hoarseness is definitely not related to any of the other ones. And then cough and shortness of breath. Shortness of breath again is everyone. So let's see, how can we remember hoarseness?
Well, she put a picture of a horse.
Yeah, but how you're going to relate that to an aneurysm?
I just started.
This might be dumb, but this might look like a horse's nose. You know, it balloons out like this, and you have like the little horse's nose right there. And this could be an ear, and that could be an ear.
That's funny.
There you go. There's your horse. Oh no, it looks like a horse's nose to me. Sometimes you just gotta have weird things to remember. Okay, treatment. How do you treat this?
Probably surgery. I
Yeah,
don't know.
that's really
You
it.
just cut them up and
Yeah, you gotta just
get in
you
there.
just gotta fix that bad boy. I mean, you can't really give them a medicine. Be like, here you go.
Do
Like,
they do like cut out that part and replace it, or
I'm sure they do. I'm sure they cut this part out and then just reattach it, or maybe they, if it hasn't ruptured yet, maybe it's like just ballooning out. Maybe they like reinforce it and wrap it with something.
sternotomy? Oh, they're just saying open chest.
Yeah, sternotomy, open the chest up that way. It's gonna be open heart for sure. Yeah, I'm not an expert in how they fix these, but that's just
It doesn't matter.
surgery.
I tend to want to know more than I need to know.
Oh yeah, me
To
too.
just shut it off.
It helps me have like a bigger picture of what's happening.
Yeah.
You ready to erase this?
She just mentioned surgical complications.
Well, obviously, there's gonna be
Yeah.
tons.
I think that most of them are related to clots.
Yeah.
Blood supply to vital organs.
But that's, that's common sense.
Bleeding.
I'm
Paralysis.
gonna erase this whole thing because we're moving on from this. Actually, do I want to erase this?
Acute coronary syndrome.
Yeah, I will.
So we're going to talk about vagina and lab.
Sad. Bye.
You worked so hard.
I know, it was a really pretty drawing. Put in effort. Where are your two friends today that were here last time?
I don't know. They're younger students. I don't.
Oh, okay.
I have a life, so
I just assume, oh,
I
you're in
don't
the same
have
class,
friends.
you're friends.
we all know each other. You know.
All right, ACS, acute coronary syndrome. ACS. Okay, so this encompasses angina, or I've heard people say angina. I don't know. I think angina sounds better, but I've definitely heard people say angina. So couple types of angina. We got stable, unstable, and variant, which they also call Prince Nettles, which I don't know why they call it that.
That is us. We don't. That's
Huh?
what did you call it?
Variant, stable, unstable, and variant / Prince Nettles. You don't have that?
Oh yeah, yeah we do.
I was about to say, I'm not crazy.
Microvascular. is another one.
Let's see.
Stable, unstable, microvascular, and variant.
Sorry. Microvascular.
Yes, I discovered pretty quickly with just table moves.
Okay, yeah.
These
These are the main three. Okay, so stable, they're stable, obviously. So this one, I like to say, is basically if you have stable angina, you're basically just out of shape, right? Like, as essentially, I experience angina walking up all those Ellen White stairs. Where it's just like shortness of breath, and you're like, gosh, I don't want to reveal to people how out of shape I am, right? Yeah, it's literally, I mean, obviously it's more than just being out of shape, but essentially that's what it is. It's pain with exertion, relief with rest, right? I don't really have chest pain with exertion, I just have shortness of breath with exertion. So chest pain with exertion, relieved by rest and what?
Nitro.
So rest and nitroglycerin. What does the nitro do?
Vasodilate.
Yep, so it just widens those vessels to allow more blood to flow through and allows the heart to calm down. Unstable, same thing. Rest, except yours is even more out of shape. So you have pain with even at rest. So pain at rest now. So these people are obviously unstable because it's like, okay, well, if you just have this one and you can just, rest and it'll fix it. But if you have unstable, it's like, okay, you're getting to the point where you need some kind of serious interventions here. So what kind of things would you expect to see on like an EKG if they have unstable?
She said ST depression and or T-wave inversion.
Yes.
But no ST elevation.
Right, because what is ST elevation?
That would be damage, right?
Yes,
No,
I see that with heart attack.
This could be damage. Okay, MI,
Yeah, so with an MI, you'll see ST elevation. I'll put that here.
She did say there could be, no changes in troponin or anything. So there's no damage at this point? Is that what
Yeah,
she's
so
saying?
this one's, they're just like, their heart is like really unstable right now, but they haven't gotten to the point where they're like having active damage, right? That because once you damage the heart, it's not like reversible. Like you can't like undead heart muscle, right? It's just dead. So
But none of it is dead at this point. It's just damage.
yeah, so it's just like stressed right now.
Or stress, not even damage, but just
Right. So MI would be damage. Unstable is just like, okay, you're about to become damaged if you don't fix it. So this one might not even respond to nitro. You might have to take more than one. I saw this one practice question. It was like, okay, they're feeling chest pain, they've rested and it's not working, and so they had to take multiple nitro, and that leads you to think that it's unstable versus stable. So, like you said, ST depression. So what would that look like?
Instead of the QRS kind of going to the baseline, it would go down in the back.
Yeah, I don't know how to draw that. Is that something like that? It's depressed because this is the baseline, so it's under something like that, right? And then what was the other one? T-wave inversion.
Yeah, just instead of having the
Yes. So T-wave.
you'll have more of a U.
So it's just T-wave inversion. What does the T-wave inversion mean? Like when you see that, like, okay, what does that mean?
Ischemia, she said.
Yep. So ischemia. What is ischemia? Ischemia
I don't know.
is reduced oxygen flow.
Okay. But not quite. So it leads to necrosis.
Yeah. So once it's gotten to the point where it's so much oxygen depletion that it dies, that's when you get necrosis, right? So ischemia leads to necrosis. And then what would a necrosis look like on an EKG?
Hold on. She said ischemia, necrosis.
Wouldn't that be the
fluids do not go
Q-wave?
away.
Is necrosis.
Muscle injury. It looks like an ST elevation.
One second.
No, necrosis.
Q-wave.
Q-wave width.
For ST elevation, I have muscle injury, and then Q-wave formation is necrosis.
Yes.
So this is like where it's just straight up dead, doesn't work. It's like a dead spot. Necrosis is a dead spot. It's like a scar that doesn't like respond or do anything. It's just there.
Yeah, it doesn't beat.
Yeah. So that would look like the Q wave formation, which is where your Q just gets fat essentially. So you have your P and then your Q awkward like that, and then your ST. So this is the Q here, and it's just really fat for some reason. And that doesn't go away, right? So Q wave, they will always have a Q wave forever and always. So like you could have someone come into the hospital and they're perfectly fine, and you see Q wave, like don't freak out. Doesn't mean that they're actively having a heart attack. It means that they've had one before.
Okay, she said inverted Q and elevated ST means necrosis and non-reversible. It's not reversible. Do you want to see the picture that's in mine? I don't know if you
Sure.
have the same picture.
You can also see, I can show you mine too.
I don't know if it's the same one. It looks like it might be. I have it your way. There's the inverted Q and then the ST elevation. And I wrote down here inverted. I don't know if I'm. Yeah, I pointed to it. Inverted Q.
Well, if
and
they're
then
having
elevated
elevated
ST.
ST, that means they're having active muscle injury. right? But like they don't necessarily have necrosis yet.
Okay, and that's what I said is the ST alone is the muscle injury and it's still reversible, but that inverted Q with the elevated ST
Yeah,
is
the
like.
Q
that's
wave
it.
formation is necrosis, and they do not go away.
Just the way you were saying? Okay,
Yeah.
okay.
So it's just this fat thing here.
Just a-
Yeah, because usually it's skinny, it's like this.
So it's wider and deeper?
Yeah. So it goes lower and it's fatter. And that's gonna always be on a patient's EKG for the rest of their life, right? Because once it's dead, it's dead. The ST elevation is showing like, hey, we're in distress right now. Like this is an active heart attack currently happening, right? And the ST elevation, which I drew before, which is
I
like
jumped ahead.
T,
Sorry.
Q, R, S like that. This is
Yeah.
like the baseline, it's just up there. So this is ST elevation.
Yeah.
So this is MI, right? Like currently happening. This one is like they've had an MI before. And so if you see that, don't freak out because that's just going to be there forever. That makes sense?
Yeah. Where were we though?
I don't know
feel
where
like
we
I
were.
just threw you off.
Oh, we were
Sorry.
on unstable angina.
Yes, I'm sorry.
It's fine. Unstable. Yeah. So you would, okay. So which EKG, don't look at your notes. Which EKGs are you going to see with unstable angina?
That was the inverted
Inverted what?
T.
T. So inverted T, you will have for unstable.
You had the answer on the board.
Huh?
I'm just kidding. I thought of it. I really did.
What
So
else?
You had the answer on the board.
It's fine. What else? One more. ST what?
Was there ST elevation?
Not elevation because that's MI, but you'll have ST depression. So the opposite. ST depression. ST depression.
By ST depression, do you just mean it goes below baseline?
Yeah.
Okay.
So you won't see ST elevation until it's an active MI. And you also won't have those biomarkers like troponins and all that stuff unless it's an MI. Does that make sense?
It would be like,
It's kind of a mess, sorry.
I'm just trying to come up with my own picture here. It's all right. I tend to draw.
Okay. So if you see troponins, what will that tell you?
That there's been damage.
They're in an MI right now, right?
Okay.
Yeah, troponins are MI, ST elevation is MI. Q wave is they've had an MI, right?
Okay.
Been had, that is not proper grammar.
I'm like, okay.
Sorry.
Whatever you say.
He's over there judging me. He's not even listening. It's fine.
Judge.
I said that you've been had an MI.
Done been
He's
had.
judging you in his periphery.
You done been had an MI.
You are now in the south.
Yeah, that is
Welcome.
true. All right. So treatments. Nitro, you might have to take more than one to fix it because it's unstable. Antiplatelets like Plavix, for example. Because again, heart's in distress. What are we worried about? Clots and things. How do we diagnose this? How do we know if someone has unstable angina other than like they're presenting symptoms? What can you get them to do to test the functionality of their heart?
Stress test?
Yep, stress
Oh, really?
test.
Okay.
Yeah. So stress tests will tell you like, hey, okay, like how much exercise can you do and tolerate, right? Before you're like done. It's like the treadmill thing, they measure your blood pressure and your heart rate and all that. They'll tell you what kind of shape you're in.
Or the, was it dobutamine? What is it? Which one is it?
For what?
The one that stresses the heart. I don't remember. That was a semester ago.
Yeah, I'm like, that's been a minute for me. All right, and then variant, sorry, let me not erase. Variant is like weird because it's not related to really these. It's like, it comes and goes and it's related to vasospasms. So like your vessels just like spasming and it's like, and a lot of the times it has to do with like other reasons besides this. So it has to do with like being really cold, your vasospasms will occur, or being stressed. You'll also see this with smokers. They'll have vasospasms. It's just something that's irritating the vessels, so they're spasming. Certain meds will do it. Cocaine for sure will.
Cause a lot of problems.
Yeah, I mean, think about it, like nicotine is vasoconstrictive. A lot of stress will cause vasoconstriction. The cold will cause vasoconstriction because you're freezing. So a lot of these things are like going to try and cause your veins or arteries to constrict. And the variant is just like, okay, they're trying to like not have that. So it's just kind of variants are random. And then for some reason, they also said that it tends to happen between midnight and 8 a.m. So like when you're at rest, it just happens. I don't know.
Okay.
But that is a very unique thing to this one that you won't see in the other ones. So if they mention anything about midnight to 8 a.m. or happening in rest and having to do with being cold or vasospasming, you know, it's the variant / Prince Metals angina.
So she says the difference between microvascular and variant is the fact that it happens during cold weather and such, and then that it's usually in the middle of the night between midnight
Yeah.
and 8.
Yep. And then treating this one again, figure out what the cause is. So if it's smoking, stop. If it's stress, maybe take a yoga class or something. But you also might put this person on calcium channel blockers to help regulate some of that, and some nitro during episodes. Just pop a nitro. I feel like we kind of went all over the place, but did we finally make sense of it all, or did we get lost?
I don't know how we ended up in MR, but there was a reason.
There was what?
There was a reason we ended up looking at all the MI stuff.
Well, because a lot of this stuff can lead to an MI.
Oh, okay.
Like an unstable angina can lead to an MI if you don't fix it or you don't like calm down. You know, like this. You see the videos of like the guy running and he starts having chest pain. He's like, "Oh, I'm fine," and he keeps going, and then he falls over and has a heart attack. You know, so like at the first sign of chest pain and stuff, you should stop, rest. You know, let your heart calm down, like pop a nitro, and maybe don't have a heart attack. You know what I mean?
Maybe not.
Yeah. So, shall I erase this?
Sure. Okay. I mean, unless you want to keep your MI stuff, because we're going into that.
Well, we'll just do it.
Should we do it?
Probably have to finish with MI. Okay, so MI is still part of ACS, acute coronary syndrome. It's just basically like exacerbated angina, like untreated and worsened angina. Because angina is really just insufficient oxygenation to meet the demand, and then MI is the same thing, but now you've caused damage, right? Does that make sense? Okay, so two types of MI. What are they?
Acute. Wait. Two types. I don't see two types. I don't know.
STEMI and non-STEMI.
That's it. Okay. Yeah, that's on the next page.
So what is STEMI? What does that mean?
That was, ST elevation MI.
Exactly. So
Non-ST
ST elevation, myocardial infarction, and a non-ST. So yeah, there's basically saying you can have a heart attack where you have ST elevation, or you can have a heart attack where you don't have ST elevation, right? So they'll tell you that a STEMI or one that has the ST.
That's a full occlusion.
Can you see that in the video? Yeah. So this would be an ST, right? This is the baseline. This would be the ST elevation. They'll say that's a full occlusion. So like a clot that's blocking off the entire vessel, right?
It leads to the part of the muscle.
So like a whole clot right there.
Yeah.
Now they'll tell you that non-STEMI is partial, right? And so you won't see that ST elevation because you've still got like some blood flow getting through. Does that make sense? Mm-hmm. Now, the other thing with non-STEMI is that for whatever reason, women tend to present that way. So even if they do are having like a full-on heart attack, women for some reason may not have. It's just much more common for women to have a non-STEMI. And really, when you look at like just the root of what's going on here is that you just have a mismatch of supply and demand of oxygen. And that can be caused from a clot, and that can be caused from all sorts of different things, but typically a clot, especially if it's kind of like sudden like that. Now, let's talk about some risk factors for heart attack. I mean, we know most of them just off the top of our heads. So what are some risk factors for that? Who's the most likely to have a heart attack?
Age,
obesity,
yeah,
hypertension, right?
type 2 diabetes.
Type 2 diabetes is a risk
Just put
factor
it
for everything.
Yeah.
Literally all. If you see that on NCLEX, circle it.
That's
Age,
actually
obesity.
what Miss Hunt said.
Is it?
It's always
It's always diabetes. No, I promise you. People that don't do a lot of exercise, sedentary lifestyle, smoking, obviously.
High cholesterol.
Yeah, and we talked about why cholesterol is part of that because it
Yeah.
blocks. It's essentially forming a clot, right? So like this could be plaque buildup instead of a clot, right? And you're still having a partial occlusion.
Okay. She said, sorry.
Postmenopause.
STEMI. She mentioned STEMI, and then she said complete occlusion of a coronary vessel by plaque rupture.
Yeah, so the plaque can dislodge. Like usually it's like stuck onto the lining.
And it leads
But
to the heart
sometimes-
vessels and
Yeah, sometimes the plaque can just like come off and just start floating down the bloodstream until it gets somewhere narrow and just gets wedged and locked in there. So that's also bad.
and it would cause an MI if it went to the heart. as
Yeah.
opposed to-
Yep, sure could. So see, these are some risk factors. Most of them we know anyways. Signs and symptoms. So how do you know if someone's having a heart attack?
Chest pain. Shortness of breath.
Yeah, they say it feels like an elephant sting on your chest.
Yeah,
It's like heavy weight, heavy pressure, like your heart's gonna explode. You're gonna have those enzymes, those cardiac enzymes on the blood tests. Nausea, vomiting. You know, that pain, the pain in your arm, pain in your jaw. Women tend to have like different signs and symptoms than men do. So they don't typically have like the stereotypical ones. They'll tend to have things that are kind of vague, like back pain. Like, okay, no one thinks back pain is related to a heart attack, but they tend to have more silent heart attacks, if that makes sense.
Women.
Yeah, women do.
Yeah. I mentioned that.
Yeah, what else?
It's because we're just.
We suffer in silence.
Yeah, I was gonna say we just don't find out our pain.
So troponins will tell you that you're having specific heart muscle injury. There's another one. There's another marker that'll tell you about.
CKMB.
I think that might be it.
It's a cardiac specific enzyme. She said they used to use it more, now they don't.
Yeah, troponins are pretty much always used.
Yeah.
There's another one. I don't remember what it was, but like it'll talk about like any muscle injury. So it's not really necessarily great because like you could have, I don't know, injured your leg muscle and it'll come back high, but it's nothing to do with your heart.
Okay.
Does that make sense?
Yeah.
Okay, so treating this, how do we treat a heart attack? Right here. Well, first we're gonna monitor them. So what are we gonna strap on them? 12 lead.
Yeah.
12 lead EKG. So we can see what's going on. What are we trying to hopefully not see?
ST elevation.
Right. So I can draw those again if you want me to.
So if they have NSTEMI, are you just not able to identify it, or you have to go off of symptoms? Or are there
Yeah, I
other-
mean, there's other things like the markers and all sorts of other stuff. You know, that's just the ST elevation tells you that you have muscle injury, and that also corresponds with the troponins, right? Because those both have to do with muscle injury, right? So you could have troponins and maybe not ST elevation. ST depression, that was for unstable angina, right? And you have the T wave inversion. That was also for unstable angina. And that one means what? What did the T wave inversion mean? Ischemia.
Yeah.
So the ischemia just means that you have reduced oxygen, right? So it's like if I'm holding my breath, right? Necrosis is where you have so much of a decrease in oxygen that it kills it.
Dead tissue.
Yeah. So and that would be the Q wave, right? The Q wave formation is the necrosis, and that will always be there forever. Does that make sense? It's like a dead spot or a scar on the heart that just doesn't do anything. So if you can remember these 4 types, that'll help you a lot, I think. What else? 12 lead monitor troponins, giving them oxygen, right? Obviously, because the whole point is that they're having an oxygen shortage. Nitro to open up those vessels. Nitro is especially helpful if they have what?
Partial occlusion.
Right, because it helps widen the
Right.
vessel even more to make room for more blood to go through. Morphine. You give morphine. And okay, so this brings us to the I think that in your notes they call it a PCI, a percutaneous,
Yeah.
what is it? Percutaneous intervention?
I wrote down what it was.
I forget what the I stands for.
Where are you?
It's the stent situation. We have to put a stent in.
Risk factors, so it would be,
Yeah, treatment.
I didn't get that far, but I remember seeing it somewhere.
Well, whatever it is.
Anyway.
It's basically another name for it is an angioplasty.
Okay.
It's where they, I'm trying to see if there's room on the video. So like, let's say this is your vessel here and a stent, they'll put like a catheter in you and then put like this wire mesh that's like a really firm material.
Percutaneous coronary intervention.
I was right. Okay, it is intervention. Sweet.
Yeah.
So I don't know if you can tell like this.
Okay.
This is like a mesh that they'll insert into your vessel. It's stronger to keep it open, to keep it from caving in, from getting blocked off. Sometimes they'll have to like chisel through some like plaque buildup to get a stent in there to open it up to keep it from constricting, so that you can always have better blood flow. So you have blood flow through the stent. Does that make sense?
Yeah.
So that's what a PCI is. Percutaneous intervention. It's also called angioplasty. So if you hear any of those, I'm more familiar with angioplasty than PCI. Or they also call it a stent. So if you hear any of those 3, now you can get this within how long? You come into the hospital, someone's having MI due to a clot. How many minutes are they allowed to have been there with those symptoms if they can have a angioplasty?
I don't know.
90 minutes.
Okay.
So they want you to have it done. They want you to have, as soon as you enter the door of the hospital with the chest pain, they
Start
diagnose you with having a STEMI, then you got 90 minutes to get in there,
Okay.
right? They can also give you, depending, a fibrinolytic, which will bust up the clots. So if you do have a clot, right, if this is what you have right here, they can give you a fibrinolytic.
To break down the clot.
Yeah, lytic means to break down, and fibrin is like the fibrous, or
Yeah.
and so what drug do we have that we know of that is one of these? Alteplase. Alteplase is the name of the fibrinolytic that'll break down that clot. So you can do those, you can do fibrinolytics, you can do stents within 90 minutes. When would you not want to use a fibrinolytic?
If they're bleeding?
Yes.
Okay.
So if there's a bleeding risk, like maybe they're at risk for having a hemorrhage, or they're having they have like different kinds of strokes. You can have hemorrhagic stroke, or like the occlusive, the clot types of stroke. You don't want to use a fibrinolytic if they're having a hemorrhagic stroke, because that's going to make them bleed more, right? So that's why you always have to like diagnose first what's causing it before you give that.
Okay.
Yes. And this, another option, instead of a stent, is something called a cabbage. Is that part of your notes too?
Yeah, it was a coronary artery bypass graft.
Yeah, coronary artery bypass graft. So this is for people that have like really bad vessels. So let me see if I can figure out how to draw this. I don't know if I can, but basically you have your, you have your heart, and you have a bunch of different arteries and vessels in your heart, right? So sometimes you'll get a stent and you'll be like, okay, cool. But then you have to come back and they find out, oh man, you have 5 blocked vessels. We could do like 6 stents, or we can do a cabbage, right? A cabbage is where they take a piece of another vein, like usually the head from your notes was the saphenous vein or the internal mammary artery. They'll take like a piece of it and use it to bypass those blocked vessels. So like they'll take a piece of it, cut it out, and then like, let's say like this is your vessel that's clogged. I don't know how, if this is your vessel that's clogged here, rather than like putting a stent in, like maybe they'll take, a graft from somewhere else to bypass it. So they'll insert a vessel here and attach it like that, so that the blood doesn't have to go this way. It can just go through the bypass.
So is she, I'm out of it. Can I draw, trying to ask a question, I don't know how to ask it.
Sure.
We're gonna have green veins. So let's say
Green veins. I have red and blue.
it's all right. Just like here's a blood vessel, and there's all these branches coming off, and there's 1, 2, 3, 4, 5, 6 occlusions. So they're grafting from here to here, like this one's fine past here. Like there's the vessels are continuing.
Yeah,
on,
so
but
they
they're
just
all occluded. So they graft to like this one basically.
Yep, they can do up to 6 vessels, and I'm sure it just depends on the anatomy.
Is that what they're doing?
Yeah, so they would just attach.
They're just bypassing all of these occlusions.
Yeah, let's say this one's blocked here, this one's blocked,
That's what I'm
blocked.
saying. Yeah.
So they'll just be like, we're just gonna take a detour.
Okay.
And so it's, rather than try to fix all of these ones, they'll just put in a new road, if that makes sense.
Got it.
Like when there's like a new traffic pattern and they're like working on the roads, they'll like sometimes make a road that you can go around. It's kind of like that.
Yeah.
Your drawing's just as great as mine, honestly.
It's green. Why not?
Yeah, so that's what a cabbage is. What else about cabbages? You can do up to 5 or 6 vessels using, like I said, the saphenous vein or the internal mammary artery. There obviously are risks with this, just like there's risks with everything. I don't think there's anything specifically else about this. We talked about tamponade already. That can be a potential complication from a cabbage, as well as pericarditis. They might have a chest tube post-surgery.
That's what I noticed. I did the cardiac step down unit, and they always had chest tubes.
Yeah. So what do we want to make sure of if they have chest tubes? What do we monitor?
Make sure that the thing is on, what is that thing called? Is on the ground, is below the chest.
So you want to make sure that the tube is patent and it's flowing, right? But let's say like they're having constant drainage, like you're measuring and it's pretty consistent every hour, and then all of a sudden it just stops. Like it doesn't start trickling off, it just stops. You're thinking, maybe the tube is occluded, right? It could be occluded, it could be clotted off, which would be bad because it can't drain, right? So you want to monitor that. It'd be normal for it to start trickling down, like maybe it goes from 20 mLs to 10 to 5, but it shouldn't go from like 50 to 0, right? All of a sudden, because that's like, something's blocking it or it got displaced or something like that. So monitoring that. Yeah. I mean, that's the basic quick and dirty of MI. Do you want to do some questions or I just quiz you on some things for the last couple minutes?
Yes, but don't count it as a reflection of your teaching. I do horribly.
Do you want me to?
I'm, you know.
Do you want me to quiz on the stuff we just did or stuff from this lecture and last lecture? Or none of the above?
Yeah.
Do we erase this or leave it
You
up?
like my answer? Yes.
I'm gonna leave this up so you can cheat and look at it.
Whatever you want. I don't.
Or actually, I might write stuff down.
I'm
I'm gonna erase this. Huh?
I'm not good at making decisions right now.
I'm not gonna. Well, fortunately, this is being recorded, so you can watch it later if you just really miss me and want to hear my voice.
That's gonna be part of my study.
You can listen to my voice as you fall asleep at night. That's not creepy at all. All
It's
right.
not Wednesday. Is it Wednesday?
Is what Wednesday?
Today.
Today's Tuesday.
Why are we?
It's Tuesday.
All right. It's just my kids with their adventurers. It's on Wednesday and someone was saying we're not gonna have it. I was like, wait, so
Okay, so I'm gonna do stuff from not just today, but also from before.
okay.
Um,
I'm gonna cheat.
this is open note.
Okay.
Open note.
What did we do the first time? We did
Dysrhythmias, CHF, hemodynamics,
Oh, we did everything.
and some shock.
We kind of went through all that.
Okay, so let's have a quiz. All right. Someone comes in, you look at their EKG, and this is what you see on their EKG. What is it, and how do you treat it?
VTAC.
VTAC, correct? What kind of treatments do you want to give this person?
Do we do defibrillation
You can do defibrillation if what?
if there's no pulse? Or no, there has to be a pulse.
No pulse, no breathing.
Okay.
This is what allows you to do what? Defibrillation,
Okay.
right?
But it has to be synchronized. So
That's
VTAC with a pulse.
Cardioversion, the synchronized cardioversion is if they are conscious and do have a pulse. Basically,
Pulseless VTAC. I see.
Yeah. basically, if someone comes in and they don't have a heart, they have a heart. They don't have heartbeats and they're not breathing, we call them dead, right? So that's when you defibrillate, but they have this going on, right?
Okay.
Now-
Rhythmless.
If their heart rhythm is asystole and they're
That's
not
where we don't
breathing
do
and don't have a pulse, you can't defibrillate because
Okay.
there's no electrical activity.
Two different.
The
Okay.
point of defibrillation is to interrupt the electrical activity that has messed up their heart muscle, right? This is showing that there is no electrical activity if there's a asystole. So there's nothing to interrupt.
So we
Right.
check for pulse. If there's no pulse, we start CPR immediately. Ask for help.
CPR for sure. If
And
they are
get the-
awake and they do have a pulse, but they still have VTAC, then that's when you would want to do the synchronized cardioversion,
Okay.
right? That way you make sure you time it just right so that you get it right where it's supposed to be. Make sense?
Yep.
Also, medications wise, what are you going to give them?
There was a medication.
There's two that I'm thinking of that you can give for VTAC. Any life-threatening rhythm, what were you going to think about giving? Starts with an E.
Oh, epinephrine.
Epinephrine. Anytime there's a life-threatening rhythm, whether that be VTAC, VFib, what else? You can also give it with asystole, and you can give it with pulseless electrical activity. So anything that's like they're pretty much dead or dying immediately, epinephrine is your best friend.
Okay.
Also, amiodarone.
That was it.
Amiodarone
And
is
it started
great
with an
for arrhythmias.
A. Okay. Oh, it's on the last chapter. That's fine. All right.
I'm gonna erase this one. Okay. Goodbye, VTAC. Let's see. All right, this is gonna be a bit of a tricky one. Maybe. Okay.
Oh man, it's a heart block.
Okay.
3rd degree.
Okay, first, before you jump to anything,
Okay.
first of all, we notice it's a heart block, so that's good. So heart block, perfect. Now, how do we differentiate between the heart blocks? We have to look at the what?
The PR
PR
intervals.
Right. So with the heart block type 1,
They're just prolonged.
it's just prolonged. So the PR interval is the same, but it's just each one is just there's a big wow, I can't speak. There's a delay between the P and the QRS, right? So this would just be like you have this over and over again, like this right here, right? That'd be 1st degree. 2nd degree is what?
So there's type 1 winka back.
Type
Back,
2 is
winka
winky back.
Wait, what did I say? I mean like the first
Sorry.
first type 2.
There's only 1st degree, and then there's 2 types of second. No,
That's what I'm saying.
gosh, between both of us, we're doing real good today. Okay.
1st degree, 2nd degree.
So this is not
So
1st degree.
the-
We can cross
no,
that
no,
out.
no. This is
Yes.
not 1st degree. But the first type of 2nd degree.
The first type of second. Right. So in the second
Type
degree,
1 2nd degree.
right? There's
Yeah.
2 types of second degree.
So type 1 was where it got longer and longer and longer, skipped, and then went back to normal.
Mobitz 1, Mobitz 2. Yes. I'm just gonna write this down so we don't confuse ourselves. Now,
Okay.
which one of these is called the winky back?
Mobitz 1.
All right. So this is winky back. All right. So do you remember my little story about Winky?
Yeah, Winky
I'm just
stayed
gonna-
away longer and longer and longer, and then he didn't come home.
I'm
one
gonna tell
night,
the story for the
and then
sake
he
of
went
this
back to
video.
normal.
So Mrs. P is married to the QRS, and we'll call him Winky. So this is Mrs. P here. This is Winky. Now, they have a strained relationship. They've grown some distance between them, right? They used to be closer, now they've got distance. And so now Winky has started, coming home later and later. So he came home late here because there's a space here. The next night he comes home even later. And the night after that, he doesn't even come home. Winky is missing right there. There should be a QRS, right? Right there. Not there, but then the next night, Winky back, right? So late, gone back. So that's why that one's Winky back. W, that's what the W is. Does that make sense?
Okay.
So that one, what was the first thing you said was 3rd degree, right?
Right, because it looked like there was no association.
It looks like what?
It looked like there's no association between the two.
3rd degree is where it's just,
There's
yeah,
no-
and it's hard to tell with my drawing
no
because you
reason.
can't see any lines.
I see what you're saying though. I see
Yeah.
you're more prolonged. I see what you're.
Yeah, I was trying to get bigger. and
I was
long.
seeing
Yeah.
no association, but
Yeah.
I do see it now.
3rd degree is like it's just completely random, and you
Yeah.
can't even measure the PR interval because it's just constantly different. At least this one follows a pattern. So like if you were to see a longer strip of this, it would follow the same pattern. So maybe it's like 2 blocks, 4 blocks, 6 blocks, 2 blocks, 4 blocks, 6 blocks. So it's going to repeat itself. Whereas 3rd degree, it's like there is no consistency whatsoever. It's electrical divorce. Does that make sense?
Mhm.
I'm erasing this.
Okay, but then the 2nd degree, no progressive lengthening. It's
Right.
just constant, and there's just a
Yeah.
random.
Mobitz
failure.
2 or 2nd degree Mobitz 2 is that the PR interval is always the same because Mrs. P is always loyal and consistent, and the QRS will either be there sometimes or it won't.
Okay.
So Winky's just like there sometimes when it feels like it and not there other times.
And that one was slightly more dangerous or whatever. All right.
That one does need a pacemaker, yes.
Yeah, you can't treat it with that.
Yes, you need a pacemaker.
Okay.
All right.
Same with 3rd degree.
Let's move on from those. I don't even know what to ask. Let's see. Okay, I'm gonna give you a list of symptoms. You're gonna tell me what they got. All right. Tell me what this patient has, okay?
Okay. Oh, dear.
It's okay, we'll think it through. Okay, so this is a patient. Jugular vein distension, pulmonary edema, S3 murmur, reduced cardiac output, swollen ankles, hypertrophy. I just kind of made this up as a patient looking at different things. So it's not like this is a textbook, but this is just like symptoms that you would see with this disorder.
Okay.
So what are you thinking? Let me know what you're thinking.
Some sort of itis, right?
Well, what does S3 tell you? What kind of, what causes this type of murmur?
Pericarditis.
I'm not talking about itises. I'm just talking about what condition causes an S3 murmur. This is the
left ventricle insufficiency or fluid buildup.
Fluid
in the left
buildup.
ventricle.
Right, so fluid buildup causes an S3, okay? So that's one clue. Now, reduced cardiac output.
That would be a result of that.
Yes. What does swollen ankles and pulmonary edema tell you?
That the heart is not working effectively. And
Right.
Yeah.
This is also
So
related to
it's-
fluid buildup.
Swollen
Right.
ankles also could be indicative of right-sided heart failure.
It could, yes. So putting it all together, what kind of heart problem is this probably?
Hypertrophy.
Let's say you also have an increased blood pressure. So that would be also increased SVR as a compensatory mechanism.
I want to say
We talked about this
just
last
heart
week.
failure in general.
Yep,
because
heart failure, but specifically,
left-sided heart failure, or what do you?
what's the fluid part?
Congestive heart failure.
Congestive heart failure, right? So all these things are caused by fluid. So
Okay.
the congestive part is like the fluid is the reason that's causing all of the heart failure,
Okay.
right? You have the buildup of fluid, it's not pumping out right, and all of the fluid starts to back up. Backs up into the lungs, you get pulmonary edema, backs up to the systemically, you get the swollen ankles. Your heart compensates, you're trying to, the heart muscle starts building around the ventricle, you got the hypertrophy. Your blood pressure skyrockets, trying to overcome that systemic vascular resistance to pump it out. It's not working. So these are the kind of signs symptoms you'd be looking for. Yeah.
Okay.
What kind of drugs do we give these people?
We usually start with diuretics.
Perfect, because fluid's the problem.
Yeah.
So Lasix all day.
Yeah.
Lasix for life.
And
Everyone
we-
gets
yeah.
Lasix. Everyone gets a Lasix.
That's true.
Yeah.
What's the other one that starts with it? Mannitol or whatever. The stronger one.
Beta blockers are helpful.
Yeah.
That because
Antihypertensives.
and again, the reason why beta blockers are helpful,
We're resting the heart. So the heart is overworking and we need to just give it a break.
yes, because it's beta blockers are technically beta adrenergic blockers, and the adrenergic part has to do with adrenaline, and adrenaline is like the fight or flight, like increases your blood pressure, increases your heart rate, and it's like that's the opposite of what we need right now. Thank
Yeah.
you.
Yeah.
So it'll block adrenaline, so it will reduce your heart rate, reduce your blood pressure, give your heart a break. You also want to give ACE inhibitors. ACE inhibitors, why? Do you remember the Ross?
Yeah, so it works on the
Can you erase this?
yeah, it works on the Ross.
I'm gonna
What was it? The
draw it real quick.
trying to think through the
Starts with the kidneys.
yeah.
So the kidneys produce what?
It was at the lungs.
What do the kidneys produce?
ADH
Renin.
Renin.
And then you get angiotensin
So
1.
that's hypothalamus.
Where does the,
Nothing else thinking out loud.
the angiotensin 1 goes to where in the body?
Does it not go to the lungs?
This
It
goes
does
to
go
the lungs, right? So
okay.
in the lungs, you have an enzyme called what?
ACE.
ACE, which is easy to remember because it's the
Angiotensin
angiotensin converting enzyme. And this turns into angiotensin 2, which is a potent what?
Antidiuretic or
Vasoconstrictor.
Vasoconstrictor. That's
So this is going to cause your blood pressure to skyrocket. So if you have ACE inhibitors, you have a pill, that's a pill. An ACE inhibitor is going to block ACE from doing its job, which means that enzyme is no longer going to work, which means angiotensin 1 cannot convert into angiotensin 2, which means you will not have vasoconstriction, you will have vasodilation. And that also helps give the heart a break. So beta blockers and ACE inhibitors are what you want to give for congestive heart failure. Okay. Does that make sense?
Mm-hmm.
Once you kind of understand what's happening in the heart, like patho-wise, like pathophysiology, like the signs and symptoms make sense, and then treating what the issues are makes sense. I think you were pretty strong with this when we went over it last time. I think it was just all the new materials like bogging the brain down a little bit. So
it's been a long couple weeks.
I bet. How are you feeling about all this stuff? Pretty good?
I think that's more,
Well, yeah.
but this is helpful, definitely.
We'll go ahead and stop there. The brain is at a point of no longer absorbing.
Yeah, I'm pretty sure that happened a little bit ago.
You could have said something.
It's okay. I started to get kind of what are we talking about?
Yeah.
Is it Wednesday? I don't know.
Well, I started calling Mobits 2 first degree. It's fine. All right, I'm gonna stop this. Goodbye.
Between the two of us, we're completely lost.
Well, it's also a lot because it's just me and you, so it's all the questions are directed towards you.
Yeah.